is Micha Maeder. He is a consultant in cardiology and a heart failure specialist in St. Gallen, Switzerland. So, Micha, please.
So, thank you, dear Chairman, dear colleagues. As a cardiologist, it's a great pleasure and challenge to speak about sleep apnea. So, the topic of my talk is sleep disordered breathing or sleep apnea and heart failure, quite a big topic. I can just repeat here that the prevalence of sleep disordered breathing in heart failure patients is high. Here a German cohort of patients with heart failure and reduced ejection fraction. You can see that the large proportion of patients has either obstructive sleep apnea or central sleep apnea. The sleep apnea patients are more likely to be males. So it's a frequent problem. And as we have said already, there are two types of sleep disordered breathing. Central sleep apnea, I will not tell too much about that because I think that Professor Cowie will cover that topic in detail later on. In short, it's a marker of heart failure severity, in some sense an epiphenomenon. There is discussion whether it is a compensatory mechanism and whether it is a therapeutic target. Obstructive sleep apnea is in most part independent cofactor contributing to cardiovascular dysfunction, which will be the topic of my talk. It can be a consequence of congestion, I will show that, and it's a question whether it's a therapeutic target. So, just in brief, again, central sleep apnea is often a marker of severity of heart failure, higher BNP in patients with central sleep apnea, higher filling pressures in patients with central sleep apnea. So, from now on, I will focus on obstructive sleep apnea, and I will just come to what I said before. It is thought that nocturnal fluid shift, if the patient is lying down, the fluid shift to the neck will increase the diameter of the neck and will increase the likelihood of obstructions by swelling of the pharynx. So, and why is then OSAs relevant for heart failure? Why might it be? So this is a landmark study by a Spanish group showing for the first time that significant, which means severe sleep apnea, is associated with an increased risk of heart cardiovascular endpoints. This was setting the stage for all the studies in obstructive sleep apnea and cardiovascular diseases. So what are the lines of evidence regarding obstructive sleep apnea and heart failure? And I will cover that in the following talk. First, there is a concept. So these are the mechanisms which are thought to contribute to cardiovascular problems in obstructive sleep apnea. The cycles of intermittent hypoxia and arousals, which have been shown beforehand in the polysomnographies and pictures, are sympathetic nervous system overactivity, oxidative stress, and systemic inflammation. Other aspects are sleep fragmentation per se and sleep deprivation. Sleep deprivation per se has been shown to induce subtle changes in the echocardiogram and intrathoracic pressure swings. So, sympathetic overactivity. If you measure muscular sympathetic nerve activity in obstructive sleep apnea patients, an established method to assess the activity of the sympathetic nervous system, then it has been shown a long time ago that these patients have a high activity of the sympathetic nervous system. If you treat them with CPAP therapy compared to placebo, then we can demonstrate that this overactivity of the sympathetic nervous system is reversed. If you take another measure of sympathetic activity, which is more closely linked to clinical tests, for example, heart rate recovery, that's the speed of the heart rate recovery after a maximal exercise test, then you can see that patients with obstructive sleep apnea who have severe disease have much slower heart rate recovery, a lower figure, than patients with less severe sleep apnea. So if you have severe sleep apnea, then you have slower heart rate recovery, and heart rate recovery is a prognostic factor in a variety of settings. If you perform a Miller-Maneuver simulated apnea, then you can demonstrate that the left ventricular strain, we have touched that in the morning, a measure of systolic left ventricular function is impaired. So we know a lot about obstructive sleep apnea and risk factors. And why is this important? The risk factors are also risk factors for the cardiovascular diseases, which might then contribute to the occurrence of heart failure. So the most important ones are hypertension and diabetes. We have a well-established association between obstructive sleep apnea and hypertension. The prevalence is increased and the incidence is increased. We also know that CPAP is antihypertensive. The effect is established, but it's relatively small and less than pharmacological treatment. Similarly, OSAs and diabetes, we have a high prevalence, an increased prevalence in patients with diabetes. OSA patients have a higher incidence of diabetes as well. The effects of CPAP, which means OSA's treatment on glucose tolerance, is less clear. The problem here is that of confounding factors. It's hard to separate the effects of obesity and sleep apnea. Now, what about OSAs per se? Not in patients with heart failure, just in asymptomatic patients without known cardiac disease and cardiac structure and function. Studies over the last 10 years or so have well established that OSAs is associated with a number of structural and functional changes of the heart. This is just an overview, the right heart and the left heart and the coronaries and the rhythm. Here's a short table summarizing that left ventricular mass is increased, systolic function, subtle systolic function in terms of strain or tissue Doppler is reduced, diastolic function is impaired, left atrial size as a measure of left ventricular filling pressures and diastolic function is increased, pulmonary pressure is subtly increased, and the size and function of the right-sided cavities is impaired. And small studies, most often not controlled studies, have shown a certain effect of CPAP. I will show some of them. This is a larger epidemiological study showing a clear association between the severity of sleep apnea in terms of apnea-hypopnea index and left ventricular mass. And this is a small intervention studies, an uncontrolled intervention study in patients without symptoms but with sleep apnea. And the study has shown that E2E prime, left upper corner, is reduced after CPAP therapy, E2E prime, a measure of left ventricular diastolic function, filling pressures, and that left atrial volume is reduced after CPAP therapy, and left ventricular ejection fraction, right upper corner, is slightly increasing after CPAP therapy. Very interesting data, uncontrolled study. We have to mention that. Similarly, effects on the right heart, right atrial volume index, right ventricular end-diastolic volume index, and right ventricular end-diastolic diameter is all improved after CPAP therapy measured by echo or MRI. Again, also in this study, non-controlled study. So what about sleep apnea and cardiac diseases which then finally end up in heart failure or contribute to heart failure? Two examples, OSAs and coronary artery disease. The prevalence of coronary disease in OSAs patients and vice versa is very high. We also know that there is a certain correlation between the apnea, hypopnea index and the severity of coronary artery disease as assessed by coronary CT in the MESA population. And this was a smaller study in patients with established coronary disease who had obstructive sleep apnea, and there was a non-randomized allocation to CPAP or a surgery for obstructive sleep apnea, and the treated patients did better. Again, a non-randomized study, observational study, but giving some evidence that treatment of sleep apnea and coronary disease patients may be important. Similar studies show better outcomes of coronary disease patients after PCI if they are treated for sleep apnea. For atrial fibrillation, the prevalence of atrial fibrillation is high in sleep apnea patients, and the treatment effect for atrial fibrillations in terms of cardioversion or pulmonary vein isolation is better if sleep apnea is treated. So if you don't have sleep apnea, or if you have sleep apnea and it's treated, you have a lower recurrence of atrial fibrillation after an intervention compared to those who have untreated severe sleep apnea. Now, what about OSAs and manifest heart failure? So we don't know too much, But we know that at least in men there is an association, it's not the case in women, between the severity of sleep apnea and the incidence of heart failure. It's hard to read, it's just what I said. Then we come back to the sympathetic nervous system, and why is this important? Not only in sleep apnea patients compared to non-sleep apnea patients, but also in heart failure patients with and without sleep apnea, the activity of the sympathetic nervous system is higher in those with sleep apnea, although per se heart failure is associated with an increased sympathetic nervous system activity. And this again can be reversed by CPAP therapy. Why is this important? We know that the activity of the sympathetic nervous system is a very important target in heart failure patients, the beta blocker story. And so obviously the heart failure patients with sleep apnea seem to represent the group of heart failure patients with a very high sympathetic nervous system activity. Now, what about cardiac function in heart failure patients and OSAs and treatment of OSAs? There are two small patients, a study from Toronto, looking at a very small group of heart failure patients with reduced ejection fraction with significant obstructive sleep apnea as well. They were randomized to optimal therapy plus CPAP for 1 month compared to optimal therapy, medical therapy alone. And the investigators demonstrated an improvement in ejection fraction in the Verum group. Similar study from Australia, pretty much showing the same. It was a treatment during 3 months. They also measured urinary norepinephrine excretion as a marker of sympathetic nervous system activity, and this was improved as well. Sorry. What do we know about the clinical outcomes of heart failure patients, HFrEF patients, the heart failure with reduced ejection fraction, sleep apnea? Not too much. There is some information here in a retrospective study that patients with OSAs do worse. So those with the high hypopnea index do worse compared to those with the low. And in this study, there was a small group of patients who had sleep apnea, which was severe and which was treated, but there was no significant effect to be seen. In contrast, in this study, also retrospective study, there were 2 cohorts of heart failure patients with significant sleep apnea. The one group was treated, the other one was not treated. This is the, This is the untreated group. This is a treated group, and the untreated group did worse. So this is what we know about the effect of sleep apnea and its treatment in heart failure with reduced ejection fraction. We don't know anything about heart failure with preserved ejection fraction. We have discussed this morning. And with the novel, we have also discussed about the novel definition of heart failure with reduced ejection fraction, preserved ejection fraction, mid-range. So actually we only know something about the HFrEF groups. However, in heart failure with preserved ejections, obstructive sleep apnea might be equally important, maybe even more important. If you look at this, this picture of HFpEF today, this so-called phenotype diversity, with some patients having this or the other comorbidity as an important factor. So based on what I have shown you about cardiac dysfunction risk factors, I think it's highly likely that OSA could be a cofactor for HFpEF as well. So the effect of CPAP, I have shown that in the separate entities which I have discussed before, and overall in the end it's a very complex interplay between obstructive sleep apnea and risk factors and cardiac diseases, and then finally heart failure with reduced or preserved ejection fraction. What we know is still little. We know there is a clear association between obstructive sleep apnea and cardiovascular risk factors, mainly hypertension and diabetes. We know some effects of CPAP therapy. We know that obstructive sleep apnea is associated with cardiac dysfunction, subtle cardiac dysfunction, which I've shown, and also with cardiac diseases associated with HFpEF, so coronary disease, atrial fibrillation, hypertensive heart disease. OSA is associated with sympathetic nervous system overactivity, both in patients without and with heart failure. And CPAP therapy has beneficial effects on these features in patients with OSAs with heart failure or without heart failure. An improvement, a small improvement in short-term studies in alpha ejection fraction following CPAP in HFrEF patients has been shown. No similar data in HFpEF patients. However, we have no conclusive data yet on the impact of CPAP therapy in OSA patients with heart failure with reduced ejection fraction or also in heart failure with preserved ejection fraction. So thank you very much.